Our lungs are covered by two layers of pleura, the inner visceral pleura and the outer parietal pleura. Sandwiched between these layers is the pleural space, which normally contains about 10 milliliters of fluid that provides a bit of lubrication so that the lungs can smoothly expand within the chest cavity without encountering too much friction. Too much fluid in that space results in a pleural effusion, which can actually hinder lung expansion. Now, pleural effusions can be broadly classified into transutative and exudative effusions. Transutative effusions are often caused by systemic diseases and result from either an increase in the intravascular hydrostatic pressure, such as in congestive heart failure, or as a result of a decrease in the intravascular oncotic pressure due to a decrease in serum albumin, like in liver cirrhosis, nephrotic syndrome, or malnutrition. Exudative effusions, on the other hand, are usually due to local diseases that may cause inflammation, resulting in increased capillary permeability. These include infections like pneumonia or tuberculosis, primary lung or metastatic malignancy, autoimmune diseases like systemic lupus erythematosus or rheumatoid arthritis, or pancreatitis. One more specific type of effusion is chylothorax, and it results from impaired lymphatic drainage of the pleura, which can happen after accidental damage during surgery, trauma, or cancer invasion. Interestingly, pulmonary embolism can cause both transutative and exudative effusions. The transutative component is thought to occur during obstruction of the pulmonary circulation, causing an increased hydrostatic pressure in that area. The exudative component occurs due to release of vasoactive mediators from the platelet-rich clots, which increase capillary permeability. Now, regardless of the cause, the symptoms of a pleural effusion include progressively worsening shortness of breath due to limited expansion of the lungs, and pleuritic chest pain, which is a sharp pain that worsens with inspiration due to irritation of the somatically innervated parietal pleura. However, like in the style of Sherlock Holmes, you should look for associated symptoms that may clue you to identifying the potential etiology. For example, fever, chills, and a productive cough may indicate pneumonia. Unintentional weight loss and loss of appetite may indicate a malignancy. Night sweats, travel to an endemic area, and hemoptysis can indicate tuberculosis. Orthopnea and paroxysmal nocturnal dyspnea can indicate congestive heart failure. History of occupational exposure to asbestos may point towards mesothelioma. Joint pain or a rash can indicate autoimmune disease, and so on. Normally, on physical exam, there are diminished breath sounds on auscultation, and dullness when percussing the affected area. Additional physical exam signs that may help narrow the differential diagnosis include peripheral edema, crackles, and an S3 heart sound, which may indicate heart failure. Stigmata of chronic liver disease, like jaundice and dilated umbilical veins, may indicate cirrhosis. A joint effusion, along with a pleural effusion, may indicate an autoimmune disease. Keep in mind, if you're effusing in two, think autoimmune. Alright, now to actually see an effusion, a chest x-ray is done. Uniquely, it's obtained both while the individual is upright and laying down on their side, called the lateral Decubitus position. Now, the goal of a chest x-ray is threefold. Diagnose the presence of a pleural effusion, then determine if it's freely flowing in the pleural space, which may clue towards a transutative effusion, or if it's stuck and loculated, which may indicate an exudative effusion. And finally, determine if we can obtain a sample of the pleural fluid. When the individual is upright, it takes at least 250 milliliters of fluid to see a pleural effusion. Now, normally the costophrenic angle, which is the angle between the pleura covering the ribs and the pleura covering the diaphragm, is sharp and well demarcated. In a pleural effusion, however, this angle is obliterated by the radiopaque or white fluid. Larger effusions can also obscure the diaphragmatic contour and heart borders, form an air fluid level similar to a half-filled cup of water, or they can form a concave upper surface that looks like a moon crescent and is called the meniscus sign, because meniscus is Greek for crescent. Also, massive effusions can push the entire mediastinum to the opposite side, which can cause the trachea to shift from the midline. Now, since transudative effusions are often caused by a systemic disease, there are usually bilateral effusions of similar size. In contrast, exudative effusions are usually caused by localized disease, and therefore are usually unilateral, or of different sizes. But there are plenty of exceptions to this rule. For example, early on in congestive heart failure, there may only be an effusion on one side, and conversely, a large pneumonia might lead to bilateral effusions. Alright, now on the other hand, lateral Decubitus films can detect effusions that are as little as 50 milliliters, and also help tell us if the effusion is free-flowing, which is where the fluid layers on top of the chest wall, or loculated, in which the fluid doesn't layer. An alternative to chest X-ray is a bedside ultrasound, and that can help determine the amount and nature of the effusion. A homogeneous black effusion means that it's free-flowing, and probably transudative, whereas a heterogeneous effusion with white septations indicates that it's loculated, and probably exudative. Now, on lateral Decubitus chest X-ray, we look at the distance between the chest wall and the top of the fluid level. Kind of like measuring the depth of an ocean, the chest wall being the seabed and the fluid level being the surface of the sea. If this distance is at least 1 centimeter, then there's enough fluid to proceed to the next step, a diagnostic thoracentesis, which is inserting a thin needle through the chest wall to obtain a sample of the effusion. This is different from a therapeutic thoracentesis, which is aspirating at least 1 liter of pleural fluid, providing symptomatic relief for massive effusions causing shortness of breath. The bedside ultrasound can be used to visually guide the needle through the chest wall, which prevents damage to nearby structures like the liver. Also, it's crucial to insert the needle above the rib to avoid damaging the intercostal vein, artery, and nerve, the van that runs at the inferior edge of the rib. Now, when performing a thoracentesis, there's a small risk of introducing air into the pleural space, causing a pneumothorax. And for small effusions, where the distance is less than 1 centimeter, the risk of a pneumothorax is even greater. Additionally, the individual is likely asymptomatic, and therefore can simply be observed. So that's why a thoracentesis isn't typically done for very small effusions. Another exception to performing a diagnostic thoracentesis is if an individual with congestive heart failure has recurrent chronic effusions. Then you don't need a sample, since the diagnosis is pretty straightforward. In that situation, diuretics are typically used as a first-line approach. A therapeutic thoracentesis may also be performed if the effusion is massive. Now, if the effusion doesn't improve, then there must be another problem, and a diagnostic thoracentesis may be needed. Pleural fluid can appear serous, which is to say clear, or it can be bloody and purulent. Serous fluid is often seen in transudative effusions, whereas bloody fluid can indicate malignancy, a pulmonary embolism, or trauma, and purulent fluid indicates an infection. Milky white fluid indicates a chylothorax, and it appears milky because lymph contains large amounts of triglycerides and chylomicrons. Now, to definitively determine if the fluid is transudative or exudative, we can use the Leitz criteria. Pleural fluid is considered exudative if any one of the following are met. a pleural fluid total protein to serum total protein ratio more than 0.5, a pleural lactate dehydrogenase, or LDH, to serum LDH ratio more than 0.6, or a pleural fluid LDH more than 2/3 of the upper limit of normal serum LDH. It's very important that you don't miss an exudative effusion, so the criteria are designed to be overly sensitive. Now, if none of the lights criteria apply, it's a transutative effusion. In that case, it's okay to treat the underlying cause and no further tests are needed. However, if the pleural fluid is exudative, then more testing is needed. If a malignancy is suspected, then pleural fluid cytology should be done to look for malignant cells. In a bacterial pneumonia, the pleural fluid white blood cell count can show a predominance of neutrophils. Now, effusions secondary to pneumonia can be simple, also called paraneumonic effusions, or complicated, also called empyema. A paraneumonic effusion literally translates to an effusion around an infection. So, it's an inflammatory reaction of the cells lining the pleura in response to the nearby infection. Consequently, paraneumonic effusions are often sterile, meaning a gram stain in culture would be negative. Paraneumonic effusions improve as the pneumonia resolves. On the other hand, empyemas occur when bacteria have actually invaded into the pleural space. Empyemas are often loculated and full of bacteria, pus, and adhesions. A positive gram stain in culture, a pleural fluid pH of less than 7.2, or a pleural glucose level below 60 milligrams per deciliter can also indicate an empyema, but they're not specific. Alright, now empyemas typically require surgical drainage with a thoracostomy or chest tube in addition to antibiotics. If a cell count shows that the lymphocytes are predominant, then tuberculosis should be considered. Supporting features of tuberculosis include a high level of adenosine deaminase and a positive polymerase chain reaction, or PCR test, for Mycobacterium tuberculosis. Typically, the acid-fast stain and culture of the pleural fluid are rarely positive. So, the most sensitive and specific test for pleural tuberculosis is a pleural biopsy, which is actually taking a chunk of the cells lining the pleura and sending it off to the pathology lab to look at the cells under a microscope. A pleural fluid amylase to serum amylase ratio more than 1 may indicate pancreatitis. However, because amylase can also come from the salivary glands, a rupture of the esophagus can also result in an elevated pleural to serum amylase ratio. Finally, a pleural triglyceride level more than 110 milligrams per deciliter indicates a chylothorax. If an individual has recurrent pleural effusions due to a malignancy like lung cancer or metastatic cancer, then a palliative procedure called a pleuratasis can be performed. Pleuratasis means obliterating the pleural space, so that fluid can no longer accumulate. This procedure can be performed by introducing chemicals like talc, silver nitrate, or the antibiotic doxycycline, all of which induce an inflammatory response that eventually results in fibrosis, effectively sticking the visceral and parietal pleura together. Another option is mechanical pleuratasis, in which a surgeon enters the lung using video-assisted thoracoscopic surgery, or VATS. Once in the pleural space, the surgeon repeatedly rubs an abrasive tool against the pleura, inducing fibrosis. Alright, as a quick recap. Pleural effusions can be transutative, which are often caused by systemic diseases, or exudative, which are often caused by local inflammatory diseases. The first step in evaluating a pleural effusion is imaging with an upright and lateral Decubitus chest X-ray, or a bedside ultrasound, to determine if the effusion is free-flowing or loculated. After that, the effusion is sampled by doing a thoracentesis, and the lights criteria are applied to determine if it's transutative or exudative. An effusion is exudative if any one of the following apply: a pleural fluid total protein to serum total protein ratio more than 0.5, a pleural lactate dehydrogenase, or LDH, to serum LDH ratio more than 0.6, or a pleural fluid LDH more than 2/3 of the upper limit of normal serum LDH. If transudative, then the underlying cause is treated. If exudative, additional tests are done on the pleural fluid depending on the suspected cause.